Here's our roadmap for today. First, assessing the risks. Second, the genetics and BRCA. Third, profiling the subtypes. And finally, staging and metastasis. Starting off with Section 1, assessing the risks and the scale of the threat. 1 in 8. I want you to just let that sink in for a second. This is the staggering projected incidence rate for Indian women by 2025. It perfectly illustrates why understanding the risk factors for this disease is absolutely critical. Right now, the rate sits around 1 in 21, but with this rapid escalation, we really need to understand what's fueling the growth. So the fundamental thing to understand here is that this is a hormone-driven disease. Basically, the longer someone's lifetime exposure to estrogen is, the higher their risk. That one single rule explains almost everything on this list. Increasing age, starting periods earlier, or entering menopause later, all of those expand that window of estrogen exposure. Having no children or having your first child after age 30 increases the risk. Throw obesity into the mix because fat tissues convert into peripheral estrogen, along with hormone replacement therapies that have both estrogen and progesterone, and you can really see how hormonal balance dictates the overall risk. Now, here's a fascinating point that totally shatters a common myth. Family history matters, right? But since we get 50% of our genes from each parent, both maternal and paternal family histories are equally important. Don't make the mistake of only looking at the mother's side of the family tree. A history of breast cancer on the father's side is literally just as critical when doctors calculate a patient's risk profile. Moving on to Section 2, the genetics and BRCA. We're identifying the genetic suspects. It's super easy to assume that breast cancer is mostly an inherited disease, but you might be surprised to learn that the vast majority of cases are actually sporadic, meaning they aren't inherited through families at all. A massive 90% of tumors are sporadic, with the p53 gene being the most commonly mutated. It's only about 10% of cases that are familial, and in those specific cases, the most common culprit is a mutation in the BRCA1 gene. When we look closer at these genetic culprits, there is a very distinct split. BRCA1, which is located on chromosome 17q, acts incredibly aggressively. It carries a massive 60 to 80% breast cancer risk, and the tumors often show up as basal or medullary subtypes. But BRCA2 behaves quite differently. It's more of a wide-ranging threat. The breast and ovarian risks are slightly lower with BRCA2, but it brings a whole host of other risks into the equation, like pancreatic, prostate, and even male breast cancers.
You probably remember the cultural phenomenon surrounding Angelina Jolie a few years back. It brought immense public awareness to HBOC, or hereditary breast and ovarian cancer syndrome, and the drastic measures required to manage it. Because she had a strong family history and tested positive for a BRCA mutation, she fell right into this HBOC category. Her story really spotlighted exactly what patients face when they're handed this genetic diagnosis.
So for patients dealing with these genetic mutations, doctors lay out a specific step-by-step risk reduction strategy. But we have to remember, this isn't just a clinical checklist. These are incredibly heavy, life-altering decisions. Step 1 is a must. Major lifestyle modifications like weight reduction and exercise. Then, if a patient chooses a prophylactic mastectomy to remove the breast tissue, it's important to know they still retain a 5% residual risk, mostly because the skin and nipple are often spared. Moving on, removing the ovaries and fallopian tubes is incredibly effective. It drops ovarian cancer risk by 90% and actually cuts breast cancer risk in half by removing the primary source of estrogen. And finally, taking selective estrogen receptor modulators like tamoxifen can reduce breast cancer risk by another 47%. All right, Section 3, profiling the subtypes, examining the pathology fingerprints. So the most common type of breast cancer is invasive ductal carcinoma. But there's another type, invasive lobular carcinoma, which looks distinctly like a single file line of cells, almost like an army marching one by one. Now, if doctors look under a microscope and can't visually tell these tumor types apart, they look for a specific E-caherin mutation. If that E-caherin mutation is there, boom, they have their answer. They know for sure they're dealing with a lobular carcinoma. You can think of these receptors as the biological fingerprints of the cancer cells. Pathologists use immunohistochemistry to look for them, and finding them is absolutely crucial because it dictates the entire treatment plan. Estrogen and progesterone receptors live right in the nucleus and are measured using the Allred score, which goes from 0 to 8. Then you have HER2, which is a membranous receptor sitting on the outer edge of the cell. And Ki-67, well, that's not actually a receptor at all. It's a proliferation index. A high Ki67 simply means the tumor cells are rapidly dividing and multiplying. Now, this brings up an interesting question. We know the HER2 score ranges from 0 to 3 plus. 0 and 1 plus are negative, and 3 plus is strongly positive. But what on earth do doctors do when the receptor test is completely borderline, scoring exactly a 2 plus? That's where the FISH test comes in. They use fluorescence in situ hybridization to look a lot closer at the DNA and definitively decide if the tumor is HER2 positive or not. If the FISH test shows that the genes are amplified, that equivocal 2 plus score officially becomes a positive HER2 result. And trust me, that drastically changes the patient's treatment path. Based on all these molecular fingerprints, tumors are grouped into distinct buckets that dictate a patient's survival outlook and their treatment. Luminal A is the most common, making up about 65% of cases. And it has the best prognosis because it grows slowly and responds well to hormone therapy. Luminal B is a bit trickier. It's often triple positive for everything with a high multiplication rate. Then there's the basal subtype or triple negative breast cancer. This one lacks all three receptors and carries the absolute worst prognosis, especially in younger patients. Finally, we have the HER2-enriched subtype. This used to be devastating, but modern targeted drugs like Herceptin have really flipped the script and drastically improved its outlook. But we really need to talk about the devastating paradox of the basal subtype. This explains exactly why triple-negative breast cancer is so incredibly dangerous. It gives this early false hope before aggressively returning. See, because these tumors multiply so fast, chemotherapy, which targets fast-growing cells, absolutely annihilates them initially. The scans look totally clear. But despite that amazing upfront response, the cancer frequently relapses super early, often within just 1.5 to 2 years. It's just a severe emotional whiplash for the patient. Let's head into our final section, Section 4, Staging and Metastasis, Tracking the Movement. When it comes to tracking this disease, doctors use a specific radioactive glucose isotope to light up any rapidly dividing cancer cells across the entire body. The investigation of choice here is a PET-CT scan. The 18-FDG molecule they use is essentially radioactive sugar. Because cancer cells are hungry and multiplying rapidly, they gobble up the sugar, causing any hidden metastases to literally glow on the scan. It gives doctors a full, undeniable map of the enemy's positions. When it comes to calculating the tumor size or T-stage, doctors follow some incredibly strict anatomical rules. In oncology, precision is literally everything. For instance, a tumor simply touching a muscle doesn't upgrade its severity. It has to physically invade deep into the chest wall muscles, like the serratus anterior, to reach a critical T4A status. Same thing for the skin. Major ulceration or satellite nodules count as T4B, but simple skin dimpling does not. And if a patient reaches T4D, which is inflammatory breast cancer, they are facing the worst prognosis out of all breast cancers. Now, medical standards are always evolving. It's crucial to note that under the latest guidelines, lobular carcinoma in situ, or LCIS, is actually classified as a benign condition, not a premalignant cancer. Another major update? If you have a tumor in the left breast, but the doctor finds swollen lymph nodes all the way over in the right armpit, and the right breast itself is completely clear, those nodes aren't just local spread. They are legally treated as distant metastatic disease. This part is super interesting. The sentinel node is the very first lymph node the tumor drains into. If doctors find only a microscopic trace of cancer there, they don't actually need to aggressively remove or radiate it anymore. If the cancer clusters are isolated tumor cells under 0.2 millimeters or micrometastases under 2 millimeters, modern protocols treat that node as negative. The medical community has realized that overtreating these tiny, isolated clusters actually does more harm than good to the patient. So if the disease does manage to escape the breast and those local lymph nodes, where does it go? What is its most common distant destination? Does it head straight to the brain, the liver, or the lungs? The most common site for distant metastasis is actually the bones, specifically the lumbar vertebrae in the lower back. The cancer uses this unique highway called Batson's plexus. It's a network of valveless veins that lets it travel directly to the spine, where it becomes osteolytic, meaning it aggressively eats away at the bone tissue. Understanding this intricate, highly structured path of destruction is the very first step in dismantling it. Which leaves us with a final thought. As molecular profiling gets better and better, could we one day predict and block the exact path of every single tumor before it takes its first step?